It's so amazing to have everybody be super quiet all of a sudden. I think it's because the dean's here. Or maybe the head of the CDC. I'm not sure who's more powerful at this moment. But my name is Vicki Fraser. I'm the chair of the Department of Medicine, and it's a pleasure to welcome you all here this morning for the Gerald Medoff Lectureship as part of our Department of Medicine Grand Rounds series. And we are super honored today to be able to have Dr. Rochelle Walensky, the head of the CDC, here with us. So I just want to clarify that neither Dr. Walensky or Dr. Potterly or I have any significant disclosures that are in conflict with this talk. I would like to say a little bit about Dr. Medoff because he is a beloved and distinguished faculty member and leader at Washington University School of Medicine who unfortunately is no longer here with us. He was born and raised in Brooklyn, and he was incredibly proud of the Brooklyn Dodgers and their role in desegregating baseball, quite frankly. And he often talked about the importance of Jackie Robinson and what that meant to his career in terms of thinking about racism and how you promote equity and fairness. He got his undergraduate degree at Columbia College in New York and his medical school degree here at Washington University. And then he did his internship and residency at New England Medical Center and Boston City Hospital, which was also incredibly formative to him taking care of underserved patients. He did his ID clinical and research fellowships at MGH, and Dr. Walensky is the former head of infectious disease at MGH, which is a great synergy as well. And then he joined the faculty at MGH and Boston Children's Hospital, covering both adult and pediatric infectious disease. And then in 1972, he was recruited back to Washington University School of Medicine as the first head of the infectious disease division, covering, again, pediatrics and adult infectious disease. So Jerry was an incredible physician scientist. He studied Candida albicans and histoplasmosis and looked at the fundamental mechanisms of amphotericin and 5-FC, which were some of the earliest antifungal agents. He was one of the founding members of the mycosis study group. He was honored by induction into the American Society of Clinical Investigation, AAAS. He was the IDSA Waltzstam Mentor Awardee, and he won the Distinguished Educator and Second Century Award and the Neville Grant Award here at Washington University School of Medicine. He started the first WashU ID T32, which now is in more than its 50th year, continuously funded by the NIH, which has fostered the tremendous trainees in infectious disease for their fellowship and research training. He also helped foster the first Washington University AIDS Clinical Trials Unit. He established the HIV clinic and was an incredible advocacy very early on for HIV and AIDS care. He had a really remarkable ability to excel in a number of areas, so he also set up the first antimicrobial stewardship program, which he got Dr. Dunnigan to lead very early in his career. He also developed the infection prevention program here at Barnes-Jewish Hospital and ultimately at BJC. He set up the Pharmacy and Therapeutics Committee, and then also this safety and quality programs, which again, he got Dr. Dunnigan to switch from antimicrobial stewardship to become a leader in safety and quality now at BJC Health System. So Jerry is known for having an exceptional eye for talent and a passion for career development. He was a wonderful mentor to me and to Bill and Clay and many others in this room. He recruited faculty fellows and built a top-ranked division pretty much from one person. He really was very passionate about mentoring and developing junior faculty, both in basic science careers, clinical, translational research, parasitology, virology, mycology, microbial pathogenesis, HIV, sexually transmitted infections, hospital epi, safety and quality, and informatics. So he really cared about all of those things and saw the importance of all of those careers in an academic medical center. And then he pivoted, gave up his lab, and became the vice chair for clinical affairs for the Department of Medicine and the associate chief medical officer for Barnes-Jewish Hospital, establishing the FIRM system, which now is our major structure for training our residents and medical students. And he also established the hospitalist program at BJH. He was an outstanding and compassionate clinician and an educator. Though many people will tell you he often went on rounds with an earbud in listening to the St. Louis Cardinals games throughout rounds, and particularly during the World Series, he was known to have given a micro lecture while listening to the World Series at the same time. He had an incredible sense of humor. He was a storyteller. He could often sit in the corner of the room and have tons of people around him just listening to these incredible stories, and he obviously was very passionate about baseball. He was a devoted husband and father and grandfather to his wife of many years, Dr. Judy Medoff, who is here with us now. So, Judy, we have a seat for you right there. Perfect. We're so glad you could be here with us. And her son, Nate Medoff, and his wife, Sherry Berger, and he also has 2 sons, Ben also, and his wife, Alicia, and then grandkids, Julia, Alex, Jonah, and Jacob. So we are thrilled that we can recognize what a wonderful family he had and what a wonderful career at the same time. So sorry, Nate, for some of these embarrassing old pictures. There might be a bar mitzvah photo in there, I'm not really sure. But now I would like to introduce Dr. Bill Powderly, who is the J. William Campbell Professor of Medicine and Infectious Disease, the co-director of the Infectious Disease Division, and the Larry Shapiro Chair of the Institute of Public Health, to introduce Dr. Walensky.
Thank you, Vicki. It is a great pleasure. Before I introduce Dr. Walensky, I just wanted to, for those of you who were looking at the pictures, you saw a dartboard that had many antibiotics labeled in it. That was Jerry's first introduction to fellows for antimicrobial stewardship, recognizing the fact that we actually sometimes didn't know what we were doing, and just throwing a dart at a dartboard was as good as anything else. He was a wonderful teacher and mentor, and a great leader, and as Vicki said, an example to all of us. I am delighted to welcome Dr. Rochelle Walensky as the Gerald Medoff Visiting Professor of Infectious Diseases to Medicine Grand Rounds. Dr. Walensky is a graduate of Washington University. She received her BA in the School of Arts and Sciences, and then received her MD from Hopkins. And after residency at Hopkins, she completed her ID fellowship at the Mass General Brigham ID program at Harvard, where she also obtained her MPH from the Harvard School of Public Health. She then joined the faculty at Mass General, where her research rapidly established her as one of the national and international leaders in the global response to HIV and AIDS. And through her research, she helped develop policies that were evidence-based, and she became a prominent and passionate advocate for equity in the care of HIV-infected patients, both here in the United States and worldwide. She was promoted to Professor of Medicine at Harvard in 2012, and in 2017 she became the Division Chief of Infectious Diseases at the Mass General. In that capacity, she was a key leader in the hospitals and the Massachusetts region's response to the first wave of COVID in March of 2020. And for those of you who don't recall, the Northeast was incredibly hard hit. And she really served on the front line, not only in terms of leading her division and the hospital's response, but also in looking after patients. And I can tell you that for many of us in ID across the country, Rochelle and her colleagues from Boston were really enormously important in advising the rest of us on what we should do and what we needed to do to prepare ourselves for the waves that were going to be coming in. And much of the response in this medical center was informed by the lessons that I and others learned from Dr. Walensky and her colleagues in Boston. She not only was leading the clinical response, but she also conducted research, and particularly on vaccine delivery and strategies to serve underserved populations, recognizing, particularly at that time in the COVID epidemic, how much an issue there was with equity in the initial phases. In late 2020, she was tapped by President Biden to become the 19th director of the Centers for Disease Control and Prevention. And I was personally thrilled that she was able to accept our invitation to be this year's Medoff Professor. So I would like to ask Dr. Walensky to take a seat, and we can begin our conversation on lessons from the pandemic for the future of public health. First of all, Rochelle, welcome back to St. Louis.
So good to be home.
So let me start just by, you've obviously been a leader in infectious diseases your entire career. Can you just give me a sense of your perspective of the pandemic from thinking about your entire professional background, not just your current role?
Yeah. First, thank you for that lovely introduction. It's so great to be back. If I might, before I answer your question, I have never given a named lecture without a few words about the person for whom it's named. I never knew Dr. Medoff, but I knew giants who knew him. Certainly Mort Swartz at Mass General, Arnie Weinberg at Mass General, and they spoke very highly of him. Our world chattered at IDSA when we heard of his passing. Certainly incredible scholar, incredible mentor, incredible way of giving back to others, and teacher is all that I knew of him and heard of him. I do have this serendipitous connection to him, and that is Ben and I were division chiefs together, Ben of pulmonary and I and ID. Our offices were behind one another. We shared a bathroom, or more likely I used his bathroom because we didn't have one in our division. So we ran into each other every once in a while. We connected in division chiefs meetings. We shared mentees, actually. And then when I received this call in November, I had my first call with the CDC with my acting chief of staff, then Sherry Berger, now Sherry Berger, and we quickly, Sherry and I became close colleagues, close friends. We had completely non-overlapping skill sets, but completely complementary, which I value so much. And it turns out Sherry's husband is Nate Medoff. So in a completely serendipitous way, I've gotten to know both of the Medoff sons. And what I can tell you is he must have been a great man, and he must have been wonderful parents, because incredible genes have passed through to the Medoff family. So I thank you for that. To answer your question, one more thing. I do think Jerry was smiling on me one day in the world of infectious disease in May, because I was asked to throw the first pitch out at Fenway Park. Now, I'm the mother of 3 boys, and my oldest son said, we have to practice because you can't embarrass us. But I will tell you, Jerry was probably smiling because the pitch made it over the plate without a bounce. We learned so much early in HIV in terms of who was getting care and access to care. We in infectious disease have long known that where infectious diseases go are not in places of wealth, but in places of poverty and places of lack of access. They quickly go there. This was I became an infectious disease doc because of my training in inner city Baltimore in 1995. I was an intern when viral loads first became available. It was a purple top to a research lab, and you ran it by yourself because your labs didn't go there, right? And when the cocktail was approved, when we first had Zaquinavir, when we first had Indinavir, watching that sort of happen in real time was really instrumental. A third of my internship class went into infectious diseases, just to give you a sense of how motivating that time was for so many of us. Fast forward to where we were with COVID, and I vividly remember sort of being at the bedside and talking with a patient about quarantine. You should go home and quarantine. And then it became very obvious that this patient couldn't go home and quarantine. And the word quarantine in and of itself is a privilege, right? To be able to have the capacity to quarantine was a privilege. So we were sort of putting all these guidelines out there, but access to be able to follow those guidelines was really not possible. It also was very obvious that the first people who brought SARS-CoV-2 to the United States were people who traveled on airplanes, people who traveled on cruise ships, people who had the resources to do those sorts of things. And then it became a disease of the more vulnerable. And so there were so many lessons that were learned in what we did in HIV and carried through what we were seeing in COVID. What was obvious for the rest of the world is what we knew in infectious disease all along, that equity played a big part of this. Lack of access, we're going to see it again in long COVID, where those who have been more commonly afflicted with the disease, who had less access to care and more comorbidities and therefore higher risk, are going to bear the burden of that disease as well. So there were so many parallels that we could see in both of those diseases.
You've raised the critical importance issue of health equity, and we've seen this in COVID, but it spans not much more beyond COVID. As the CDC director, how do you think we need to go, both in terms of health policy and as a country, in terms of addressing equity in healthcare, and how do we do that in a way that truly gets to the root of the problem?
Right. So I think that we have a lot of work that we need to do. I'm proud to say that in April, just weeks after coming to the CDC, we at CDC declared racism a serious public health threat. And in doing so, over 200 public health departments around the country have followed suit. So we've made a lot of progress in people knowing and focusing that this was an issue that we needed to work on. I have challenged our agency specifically. I have said to our agency we have a new strategy for health equity, and said, we have spent a lot of time documenting a problem in health equity. You don't need to look very far to say it's true in maternal mortality, it's true in chronic diseases, it's true access to care, it's all true. And I said to the agency, I don't want to document the problem anymore. I want to implement things that will fix the problem, because we continue to look, and we will find it wherever we look. And so it was really inspiring for the agency, I have to say. People who are tired, who have had a hard couple of years, to be able to move forward in something that is really inspiring for them to work on. Each center put forward numerous proposals on how to implement a project related to them that would address health equity. We just had our first MMWR that looked at vaccine uptake among LGBTQ communities. That wouldn't have been possible because we didn't collect data on LGBTQ communities. So now we do, and now we can look. So, those are the things that I really want to continue to do. I do think one of the challenges has been the public health workforce itself. And the fact, I learned so much from our HIV clinics, community health workers. And the power of those community health workers to do things that I was completely unempowered to do. I remember one vividly where a patient was lost to follow-up. We were very worried about her. And we sent this community health worker to go find her. He did, and she said she wasn't coming because she had alopecia from her HIV, and she was too embarrassed to come to clinic. And he said, if I buy you a wig, will you come to clinic? And she said yes, and he showed up with her wig, and into clinic she came. And so that's what community health workers can do. And if we had community health workers sprinkled across the nation in our churches and in our, community-based organizations who had done blood pressure control, who had done, diabetes training and nutrition, when it came to vaccinating this country, they would have been trusted people on the ground to have people come to and say, yeah, you should get that vaccine. So I think there's a lot of work that we need to do. We certainly need a public health that is diverse as the communities we serve. We need to upskill that public health workforce. So there's a lot of work that we need to do. We're working at it at CDC, and I think we have work to do across the country.
You brought up the public health workforce, and you and I were talking previously about one of the challenges that we have at the moment, and that is burnout, the mental strain of this illness, this 2 years of a pandemic. I wonder if you could comment both from the workforce perspective, but also on the general public health issue, because a lot of times when we talk about public health, we don't talk about mental health.
Right. Well, I mean, there's a lot packed in there.
I know.
So we had an MMWR several months ago that looked at the mental health of our public health workforce and noted about 2/3 of our public health workforce had a depressive diagnosis, anxiety, 10% had suicidal ideation. I mean, real challenges in our public health workforce. So when we look at how we're going to scale up that workforce, we need to both bolster the sort of value of the workforce. So if you look, there was a study that was done that looked at public health before the pandemic. In the last decade, between H1N1, Ebola, Zika, and now COVID, our public health workforce is somewhere between 60 and 80,000 jobs in deficit. It's extraordinary. And we've lost thousands of jobs in COVID. And then it's not that we've lost the jobs as people have vacated them. It's there. And so when we think about what we need to do in public health, it is not just scale up our workforce. We need to make sure that that workforce feels valued. We need to make sure it's a revered place to be. We need to make sure that there's longitudinal funding. It's not, 3-year cycles, because you can't hire physicians on 3-year cycles or public health experts on 3-year cycles. We need to make sure that the resources and funding is disease agnostic. It's a real problem that our, sexually transmitted infection budget is a line item, and that when we want to use those folks as contact tracers, because those were the best people to do it, that we needed permission to borrow from this budget to go do these things. So that's the kind of infrastructure changes that we need. We need laboratory infrastructure. We now have genomic sequencing that we can do all over this country, but do we have genomic sequencers and genomic epidemiologists across this country who can interpret that? Do we have the laboratory infrastructure? And then we need a lot of work in our data monetization. And people who have read some of the challenges of this pandemic early on know that there were public health departments that were receiving lab tests by fax. CDC was never had the infrastructure to receive a reportable disease at 1 million cases a day. Reportable diseases are things like measles and gonorrhea and syphilis. That we don't get those at 1 million cases, unfortunately. But the infrastructure that was needed in order to receive those kinds of data, the public health infrastructure in this country was too frail to do.
Some of the questions that I have for you, I got from some of our trainees, and one of our ID trainees asked a question that I think fits into what we've just been talking about, and that is, to what extent does your ID medical background help you in this role, because it's not a traditional public health background?
Yeah, it's interesting. CDC's guidance is public health, right?
Mm-hmm.
We provide guidance that has to be implementable in New York City and Navajo Nation and rural Montana and Guam, right? That's the spectrum of our public health recommendations. And increasingly through this pandemic, people have wanted our public health guidance to say to them, can I visit grandma this weekend? And so that's, it's very, and I have equated it before to, like, nobody goes to the CDC guidance to say, can I have the fries at Shake Shack today? But that's what they really want from us in this moment, right? So it's been this, and so wearing my physician hat, I certainly know how to give individualized advice. But this balance between what the public is asking of us in this moment at CDC for public health information and what we generally think of as people going for their individualized information based on their individual circumstances, their individual risk tolerance, has been a really interesting line to walk.
So 2 years into this, when you think about the pandemic, what did we get right? And what do you think the opportunities will be if we face something like this again?
Nobody will ever know the counterfactual of things that we could have done better or really did well. So it's interesting to think about this. We delivered in a year 550 million vaccines. I mean, that's extraordinary. And if you had asked a priori, would we have been able to do that? I'm not sure we would have. Was it enough? Do we need to do better? Do we need to do more? Yes. But that's extraordinary that we were able to scale up. Well, we were able to have a vaccine in a year and then scale up vaccine delivery in an extraordinary fashion across this country. So that, I think, we can talk about the challenges of those who are vaccine hesitant and the divisiveness there, but we were able, for people who wanted a vaccine, it was available to them, and even for people who didn't, we were able to move the needle on many people. So I think that is one thing. Another thing I'm really proud of is our ability to quickly get data out. Now, we will always have people who say we're not quick enough. And CDC has been hit for saying, yeah, CDC gets a data point and you'll see it in JAMA in 2 years. I've seen that before, right? When we said, we need vaccine effectiveness data as fast as we can have it, because everybody wants to know how well this vaccine is working and is it waning. And over the last year, I will say we've published an MMWR every 48 hours on average, which is kind of extraordinary. We now have infrastructure in vaccine effectiveness leveraged from our vaccine effectiveness work in flu. We have numerous platforms through multiple collaborations and multiple different cohort studies, pediatric, adult, ED, hospitals. And we now have the capacity, which is a data modernization sort of pedal to the metal, of linking in 29 jurisdictions, so 2/3 of the United States population, vaccine immunization data to testing data, those two did not speak, to death data. And because of that, we can now, within 4 weeks, look at vaccine effectiveness for cases and deaths for 2/3 of America. We can stratify it by age, we can stratify it by date of vaccine, we can stratify it by which vaccines you got. That's a lot. That's been a lot to be able to do. And then maybe the third thing I'll say is our ability to scale up sequencing and scale up wastewater and scale up syndromic surveillance in ways that I think are necessary for this moment and will serve us well in the future. Where could we have improved? Well, I think I can tell you where I was when the CNN feed came that it was 95% effective, the vaccine. So many of us wanted to be hopeful. So many of us wanted to say, okay, this is our ticket out, right? Now we're done. So I think we had perhaps too little caution and too much optimism for some good things that came our way. I really do. I think all of us wanted this to be done. Nobody said waning when oh, this vaccine's going to work. Oh, well, maybe it'll work, it'll wear off. Nobody said, well, what if the next variant it's not as potent against the next variant. And then maybe the other thing I'll say is this area of gray. I have frequently said, we're going to lead with the science. Science is going to be the foundation of everything we do. That is entirely true. I think public heard that as science is foolproof, science is black and white, science is immediate and we get the answer and then we make the decision based on the answer. And the truth is science is gray. And science is not always immediate, and sometimes it takes months and years to actually find out the answer. But you have to make decisions in a pandemic before you have that answer.
It's interesting. I mean, one of the first things I say to our ID fellows when they start their fellowship is, in your residency you learn black and white because you have to know what to do in a specific situation. In fellowship we'll teach you grey. But I'm going to put you on the spot though by saying, okay, and recognizing that uncertainty, where do you think we're going with COVID? What do you think the next couple of years are going to look like? And I will start by saying I know that this is not certainty.
Right. So this is a safe space because every piece of advice I've gotten is don't predict what's going to happen. So I have no idea what's going to happen. But when I think about what the years ahead look like, and I don't even mean the months ahead, I think that overall our immunity is going to hold us in good stead. I don't know whether we're going to need another boost, and I don't know when. And I don't know what that's going to look like. But I do think ultimately we will have good level population immunity for variants that come our way. And that even if surges come, the amplitudes of those surges will be less. And that ultimately we will have a coronavirus that will, it will lead to death in some people every season. And that we will then tolerate in some way. I do think life may change. We were having this conversation yesterday about mask wearing and whether we in hospitals will be wearing masks, the way we wear gloves after the HIV, after HIV, and whether, my husband's a pediatric oncologist, will he ever go into a bone marrow transplant room without a mask on the way he used to? So, I think that there will be things that we learned here. I mean, I haven't had a cold in a really long time. And I suspect that we don't miss those. So, I think we've learned something here.
So, I used to say that the thing that keeps infectious disease doctors awake at night, this was pre-COVID, was a new virus to which we had no immunity.
Here we are.
The issue is that this will happen again. It may not be in our lifetime. I hope it's not in our lifetime. But it will happen again. How do you think we can better prepare both nationally and globally for a potential new pandemic?
So I think our data sources need to be key. We need to be able to have a full line of sight, sort of almost like a 30,000-foot view of all of the respiratory viruses that could potentially lead to this. And we're working on that. We started a new Center for Forecasting and Analytics that will be able to model and forecast what could be coming. And again, data sources, really important data sources to feed into that. And that will be academic collaborations and industry collaboration. So I'm really excited about launching that. I think we need a public health infrastructure that's ready to handle it, because I think ours was really too frail to be able to handle it at this time. And I do think that if we had more health equity in this country, that we wouldn't see these great disparities between, and in fact, I think we would all be healthier and we would all be able to tackle it better.
So this is a question from one of our ID fellows. As an infectious disease physician, I find it reasonably straightforward to be able to estimate risk of infection with COVID. However, I find it very difficult to measure the non-ID aspects of the COVID epidemic.
Yeah.
And the CDC has had to make some tough choices. And how do you approach making these decisions with competing risk benefits, balancing the infectious risk with the risks to mental health, the economic risks, all of those things?
That is such an important question. The easy answer is I know I'm going to be wrong for half the country. so now that I've accepted that, or some fraction of people will be unhappy. But no, it's a little bit tongue-in-cheek. But one of the things I think that's really been a challenge here is On the right side of every news screen is the number of cases and the number of deaths from COVID. And that's because we're counting them, and we're looking under the lamppost of all the cases and all the deaths. And there have been so many other things that we're counting that don't make the headlines. Opioid deaths, mental health challenges, screening for cancer screening. I'm sure you have heard from colleagues. I've heard from colleagues of people who came in, whose elective surgeries were deferred, who now came in with metastatic disease. So we're not tallying that as much. I think we will be tallying that in the future, but we need to make decisions now. And as I said, those decisions have to be related to, they have to be able to be applicable to New York and Navajo. And so it's a lot. We get a huge amount of feedback. Our COVID-19 response at CDC is 2,000 people. So we have people in education who are reaching out to schools and understanding what the issues are at the school level. We have people reaching out to all of our jurisdictions. What are wastewater surveillance? Well, I talked to the state health official in Alaska. They can't do wastewater surveillance. They're on septic tanks. So we can't make policies for wastewater surveillance if we can't apply them across the country. So we do a lot of outreach and get a lot of feedback, and that's really one of the gifts of this multidisciplinary group that is CDC, incredible talent. And then somebody's got to make a decision, right? And so you take all of that information, you learn from all of your subject matter experts, you have a sense of where you need to go, and sometimes, we might be faulted for not making exactly the right decision in the moment, but I don't want to be faulted for not making a decision, because that in and of itself is a decision. People were surprised by our infection quarantine guidance that came out just after the holidays. We needed to make a decision. Something needed to be done because we were about to see 1 million cases a day. And we were hearing about hospitals who couldn't get blood culture bottles because FedEx wasn't delivering. They had too many people out. So we needed to do something. Those are the kinds of things that go through our mind every day.
And, that's an interesting comment, because I think that is actually also one of the keys that comes with physician training, and particularly infectious disease training, is that doing nothing is a decision.
Exactly.
And often, it's not like you can say, I'll get a committee together and come back in a month.
No, you can't.
So let me pivot a little bit, because I got a really interesting question to put to you, which was that in the spirit of President Kennedy, what can we do for the CDC? And as you're thinking about that answer, I'd like you to think about it in perspective of 3 different potential stakeholders. The first is a medical school like ours that educates the next generation of physicians and healthcare providers. The second is a major academic medical center like ours that does high quality cutting edge research. Mm-hmm. And the third is individual physicians, doctors, medical students, healthcare practitioners. So it's a big question. Yeah. And we can take our time with it, but I think it's a really interesting thing about sort of everybody's expecting the CDC to do things for them. Yes. What can we do for you?
Well, thank you for that. At the med student level, and I love talking to students and trainees, I just really do, so this is just a thrill for me. But at the med student level, we need to, and I would say nursing level, public health school level, all of those, we really need to train the next generation. That generation has to be as diverse as the populations that we need to serve in this country. So I would say working really hard to make sure that our next generation of trainees, and really to keep, we were talking last night about, I am worried about our nursing profession. I have heard from our nursing profession, we all know that there's a shortage of nurses. We all know that nursing is a challenge, just in terms of keeping nurses engaged. I'm also hearing from nursing schools that they don't have enough faculty to teach. and that they are rejecting nursing students because they don't have enough faculty to teach. So here you have this big pool of people who want to become nurses. How do we keep them engaged? What are the things that we can do to make sure that they still are motivated to become nurses or to become helpful in healthcare? So that, I think, is really true at the student level. At the faculty and academic level, really training the next generation, right? That is what we need to do. There are so many important voices that can be heard to support public health and to support our next generation. One of our colleagues in ID, Rafi Landovitz, said to me, "This is our Super Bowl moment." Right? We're tired, and I know what ID faculty do in a pandemic. We're all tired. This is what we were called to do. This is what we trained for. We would kind of never hoped we'd be here, but this is what we were trained to do. And so inspiring the next generation to do so. I'm encouraged that applications are up. I'm encouraged, but inspiring. The other thing I would say is to use your voice for advocacy, which I very much believe in. But also, one of the things that in the media now, there are a lot of people who are using their voice that may or may not be helpful for public health. If people are disagreeing on, we can disagree on in the weeds of what a decision is, and I'm certainly happy to take the criticism. Certainly, I've had it, but if the message is not often to the public that public health is a good thing, then that decreases public health in general. So our messaging, I think we just have to be clear about. And then, at the individual level, I would just say as providers to listen. I had a social worker in our HIV clinic when I was a fellow who used to teach me how to give a new HIV diagnosis. And she said, the first thing you do is you say, your HIV test came back positive, and then either that means you have HIV infection, and then you don't say anything else. You wait. And it's a forever wait. But the first thing that comes out of somebody's mouth is usually the most important thing to them, and then the thing that you can address. And it could be, am I going to lose my job? Where am I going to get meds? Is my baby infected? You don't really know what that is unless they say it first. And so, people have often said to me, how do you convince people to get vaccinated? And the answer is, well, you listen to the reason they haven't been, right? Because you can't really address all of the reasons. You have to sort of say, what is your reason?
Sorry, excuse me. I wanted to take on one aspect a little bit further, because I do think it's really important. You talk about evidence base, and your background is entirely about developing evidence from which policy comes. And I think so much of the challenge we've had in this country and elsewhere has been the rejection of evidence and the rejection of science. So again, not putting the onus on the CDC, but how does an institution like ours, which is really a powerhouse of biomedical research in our medical school, how do we think about our role in not only generating the evidence, but translating that into policy?
I had frequently, when I was trying to come up with a question, a science-based question, or aims for a grant, so much of what I did is I would look to guidance and say, well, where is C3? Where is the evidence missing? Where are we, the C3 level evidence is, we don't have the trial, we don't know, expert opinion, how do we make this decision? That's really where I sort of sought to get evidence. How can we inform new decisions? The rejection of evidence in this moment, I certainly hope that's not long term. I do think that there's this unique divisiveness that is not in this moment, that has not helped us through this real challenge that we've had. But I don't think that that's long term. But I tend to say, what's the most important question? Because as a mentor once said to me, Ken said to me, if it was an easy question to answer, somebody else would have done it. So go after the one that is going to be hard to answer. Go after the one that's going to be the Science and New England Journal paper, because it's hard, right? Back to John F. Kennedy.
So let me turn to a couple of specifics. The first is, and you touched on it already, is the opioid overdose. Because last year, over 100,000 Americans died as a result of the opioid crisis, and those numbers are staggering, and they're rising every year. So, what new approaches has the CDC been thinking about to take to try and address this particular public health crisis?
Which was the public health crisis before we started. I think that, the two things that we were all talking about before COVID was antimicrobial resistance and opioids, right? And those are still going to be huge problems. Both have gotten worse, right, through this COVID pandemic. I had the great pleasure as vice chair of HIV/MA to go to the Hill and to meet with congressmen about the importance of the opioid epidemic just before COVID started. And what was striking to me, first of all, is usually I'm only permitted to my Massachusetts, people only wanted to see me if they were Democrats, and several Republicans met with me, which was a first for me, all over opioids. And when I would meet with them, I would talk about endocarditis, I would talk about spinal epidural abscesses, and they had no idea what I was talking about. So they knew opioids as death or survival. And we in medicine know of opioids as many of the long-term manifestations, mental health and medical, and other medical. What I would say, we're working hard in this. We have funding now with 47 jurisdictions and 47 states, DC, two territories and 16 other cities, to do more in prevention, to do more in surveillance, to look at surveillance of opioid-related emergency department visits, to understand the scope of the problem, to look at adverse childhood events and how they lead to opioid use, to collaborate with law enforcement. Here, this is really the multidisciplinary beauty of CDC. We collaborate with law enforcement to do this, but we have to look at community-based organizations and assist them in prevention and surveillance and understanding, to look at polysubstance use and the impact of polysubstance use. So we have a lot of work that's ongoing here and a lot more that we as a society need to do.
So again, I want to switch into another area that is dear to both of us. So in 2018, the government developed a very elaborate plan, included the CDC as a critical partner, to eliminate HIV transmission by 2030. Has COVID stalled that? And what do we need to do to achieve that goal?
I think stalled, I'd like to say it's not stalled. Certainly there have been a lot of activities. What I will say is the COVID response has benefited greatly by the experience of the HIV research community. Our COVID guidelines look exactly like, and in fact have many of the people, the same people on them, our COVID treatment guidelines, our clinical trials, our global collaboration. I speak every Sunday with South Africa. It is, all of the HIV researchers that we all know. So it's benefited hugely from that network, the treatment networks and clinical trials. But no, it has not stalled. And in fact, we just submitted a new round of funding of $117 million to jumpstart more of it and make sure people know that the HIV, it is not stalled. Among the things that we learned during during the COVID pandemic, I think one I learned personally was before I was in this role as part of HIV/MA, we were doing listening sessions, and we were hearing a lot that actually our adolescents and our youth love virtual visits, right? They don't want to come. Sorry. They're happy to listen to us virtually. But so we might have a new way to access some harder to reach populations, and that really might serve us well. The other is self-testing. There's been a lot of new promising data on how we use self-testing, and mail home tests, and how the at-risk community could use those tests, give those tests to their partners, and really ramp up our diagnosis. So another $9 million going to community-based organizations to ramp up self-testing demonstration projects. So a lot of work is being done. I will also say we were able to get our flagship funding grant, PS 1802, did I get that right, Sherry? To actually support PrEP ancillary services, which I think was really key. One of the big challenges with PrEP was our ability to support STI screening, to support the laboratory work. The drugs were paid for, but we couldn't support the laboratory work, so we were able to do that as well. So a lot of work that's ongoing.
Yeah, I will make one comment because that we've learned, and I think it touches on some of our earlier conversation. I think you're absolutely right. There's a generational difference in terms of the acceptability of things like telehealth. But telehealth also raised inequities because of the access issue of poorer people to stable internet, to stable opportunities to actually engage. And so I think, again, if we think about that, we have to think about it with an equity lens.
And so many of us think about the equity lens of the urban poor, but there's a rural poor that we've talked a lot about. Frontier. How do we get Navajo, right? How do we get to across the country?
You mentioned South Africa. How does the CDC balance its domestic role in the United States with its global role in global public health?
Yes. We have collaborations in 60 countries. We have people around the world. And I have had the great pleasure over the last couple of months, I've been working hard to meet with every country director around the world. And so we have a keen eye on that. What's been really interesting as I've done so is, when you speak with a country director in DRC and you want to talk COVID, that may or may not be the most important infectious threat that they have right now, or Ethiopia, or health threat that they have right now. And it's actually pretty humbling to sort of anticipate that you're going to have a conversation about one disease and realize that that is actually not the most important challenge that they have. We have to vaccinate the world for COVID-19, and we have to do that in the context of vaccinating for measles in Ethiopia. So we're doing a lot of that work, and what I will say is the beautiful part of our country offices is the trust that they have with the ministries of health there, the trust that they have with the people there. You talk to folks in Nigeria and they will tell you that much of their COVID plan was assisted by the CDC country offices, and truly incredible dedication from people across the world. So yes, we're active in that.
Yeah, your comment did remind me though that war is very bad for public health.
War is bad for public health, yes.
So we've talked about a lot. Is there anything that we haven't talked about that you'd like to address, or any other additional comments you want to make?
It's just fun to be here. I know what I don't know what the last 2 years have been like for you, but I do know what the year prior to my coming to CDC was. I know how challenging it is to train during this. And I'll go back to the Super Bowl moment, right? This is what we were meant to be doing in this moment, and to just inspire the next generation to do so, because it's a gift. We're tired, and one of the things that was very obvious to me as division chief, and I'm sure to you, Bill, is we are trying to deliver incredible care to really sick people, and at the same time, the child care closed, and mom is home with COVID, and so just because we're healthcare providers doesn't mean that we are immune, so to speak, from all of the other challenges that COVID presents. Milestones lost. And so I just want to acknowledge that and thank you all for what you have been doing over the last several years.
So, thank you.
That was really terrific, Dr. Potterly. Thank you so much for those questions and moderating. And I want to thank the Medoff family, Dr. Judy Medoff and Nate and Sherry for being here with us. And I want to thank, all of the incredible support we got from the CDC and from our medical public affairs and security and everybody in ID that made this possible today. So we're really very thankful you could be here with us. We are big supporters of the CDC and infectious disease and everything you do. So thank you very much. So we're adjourned for this session.